Um, I think this is a new beginning for Fine. As you know, Fine has been extremely active in this COVID time. And first there were these webinars for consultants, then there is a office practice series going on, and then Tuesdays you have the theory classes. So for student, we are adding a new module on Thursday, which is which is geared to the practical examination for your DM and DNB. So there will be long cases, there will be short cases, and there will also be Viva preparation like EEGs, EMGs, radiology, Viva OC questions, multiple choice questions, short exams. So it's like the practical exam that you face. And one good thing of the webinars is that you can get um, experts from everywhere, and you can also get students from everywhere. So today you have a student presenting the case from Bombay, and you have a very well-known expert, Dr. Suvarna Alladi. Welcome, Suvarna, to the Fine thing. And as you all know, she is a dementia expert amongst many other facets of neurology. So Prachi is going to present, and Dr. Alladi is going to moderate the session. So let's say we're starting with this new thing. And before I hand it over to Prachi to start, Sudhir, are you listening?
Yes, I am.
Sudhir? Yeah. I think we must all, wherever we are, we must clap for 5 seconds for Sudhir. He's done such a fantastic job in this COVID time. So Sudhir.
I'll just take 1 second.
Yes.
What Satish said, there are going to be 3 ways the students can take part. One is attendees, that means sitting down in the hall, so in the auditorium, so to say. But even from there, you can ask a question in the chat window, or you can put up your hand, raise your hand, and you will be allowed to speak. The second way is you email Dr. Devashish Ruikar that you want to take part in the case discussions as a person who's going to be asked questions and who'll answer. So in the next whatever session, you will be included. And the third way is what Satish said, if you have a very good case which you think other students across India should know, then you email the case and the details to, again, Devashish, and Devashish, Satish and Rakesh will decide according to their schedule which case to take. Okay, go ahead.
Sir, we have Dr. Devashish Ruikar, and I think he wants to show a slide.
Yeah, Devashish, you're most welcome before we start. Devashish is the coordinator along with Dr. Rakesh Singh. We have 2 Rakesh Singh, so this is senior Rakesh Singh. Devashish, can you get your slide?
Yeah, this is Dr. Devashish. I think, yeah, this is his screen only. So I think he's just displaying the instructions for the case presentation session.
Yeah, very nice. So let's keep it there for a few seconds more.
We can know who you are and from which year of residence you are there, not as a mobile name Galaxy 123 or some small nicknames like that. So please rename yourself like name, year of residency and the institute. And if you have got good cases, like what we call as exam cases, kindly you can send to us. So that's what the small instructions for all of you. And then I will hand over the things to Sir and Prachi. Thank you. Yeah.
Yeah, Prachi, please.
Yes, ma'am.
Yeah. So a very good evening to everybody. A very good, fine Thursday evening. I'd like to thank Dr. Khadilkar for this opportunity, Dr. Sudhir Kotari, Roop Gulshahani, and the entire FINE group. This is the time when residents are either resting from their days of work with COVID patients, non-COVID patients. This could also be the time when you're resting, watching a film on the sofa. But I have been told that this is the time residents want to learn. This is I think, a good time to be together to share concerns about cognitive neurology and more. I'd like to introduce Dr. Prachi. She is a third-year postgraduate resident living in a hostel where half of them are COVID positive, she tells me. And she's going to be presenting a case. The aim of this cognitive neurology case discussion will be two. One will be to illustrate how comprehensive history and focused clinical examination can lead us to making a fairly accurate diagnosis. This is for postgraduates of neurology. And the second aim will be to resolve the dilemma when we are faced with a case that has not read the textbook as we know it, and how to approach the case so we make a fairly accurate diagnosis, but at the same time have the confidence to be an outlier, think out of the box, and really see what is happening so we are able to help the patient and his family. We have two people on the hot seat, Dr. Fahim and Dr. Reshma. Both of them are at NIMHANS. They have helped Prachi develop this case, and they will participate as both to give their insights and also to ask questions and to be asked questions. We are hoping this will be a model for future case discussions where some people can volunteer to be on this hot seat. We would like to recreate a classroom where we engage in an active case discussion with details of the patient. And as mentioned earlier, the chat box is open. The raising hand option is open. Please feel free to ask questions. There will be time to ask them, but at any point you can put in a question and we will address them. So over to Dr. Prachi Barbalia for the case presentation.
Thank you, ma'am. So, patient is a 57-year-old male, resident of Mumbai. He's a vegetable vendor. Informant was wife who was reliable. He presented with the chief complaints of change in behavior since 3 years, difficulty using his left upper limb since 2 years, and multiple falls since 2 years. He was apparently all right 3 years back when his wife noticed change in his behavior. He had become irritable and would easily get angry at people. At his shop, he would get agitated on the customer. This behavior is progressively increasing. That since 1 year, he has also been abusing his wife.
So, Prachi, can you give us a little more information about his behavior with regards to his irritability and abusive behavior? The reason I say this is because the most common behavioral symptoms that one comes across in a person with a cognitive disorder is irritability, aggressiveness, and anger outbursts. And these are very non-specific. They can occur across the range of dementia subtypes. So whether it's Alzheimer's disease, whether it is frontotemporal dementia, whether it's fever even, I mean, you don't even have to have cognitive disorder. Irritability, aggressive behavior can occur in the beginning of the disease, towards the middle of the disease, and even as far as advanced disease. And this is very important because it's an important cause of caregiver stress and burden. But the problem with these behaviors are that they are not localizing in value and they are non-specific. So you mentioned that this behavior is increasing since a year and he has been abusing his wife.
Yes.
Will you be able to give us some pointer which will maybe help us to localize this symptom? In what way is he abusive? Is there anything to suggest a frontal disinhibitive behavior? or is it something to do with his with the frequent memory loss? What is this abuse that he's engaging in?
Yes, ma'am. So he is mainly having verbal abuse towards his wife. He uses swear words, and there's no physical abuse. But so he never used to be this kind of a person previously, and now he started having verbal abusive language towards his wife. So that is.
That is very helpful to know that he's using swear words, because this definitely suggests disinhibition. It's a feature of frontal dementias. But again, as I mentioned, we would like to know how his pre-morbid personality was. Was he the kind who was abusive before, and has it just become worse? So, and that will also help us to see if there's been a recent change in his status.
Pre-morbidly, he was absolutely like a very loving and friendly person. Never used such abusive language towards anybody, be apart the wife. So this is one thing that the wife was really bothered, that how did he started using swear words against me. So this is a definite change from his baseline personality.
Right. Thank you. Can you go on?
So there's also a history of excessive eating and excessive inappropriate laughter. However, there are no food fads or any repetitive behavior. He has lost interest in activities which would previously interest him. He is not bothered about his business, and he doesn't get involved in discussions at home and prefers to stay aloof. However, there's no feeling of hopelessness or sadness.
So when it comes to these symptoms, can you tell us what you think about these symptoms? What are the conditions where you get a loss of interest in activities which would previously interest him? So what are the possibilities there?
So it could either be secondary to apathy, or more commonly depression, which can occur in anybody. So it can be so this loss of interest can, or it could be because of severe cognitive impairment, that he is to a level that he cannot interact with things around. But the main difference is mainly it is seen in apathy as well as depression for any kind of psychiatric disorder.
Yeah, so it would be important for us to distinguish between the two. So is there anything in the history that will help us decide if it's apathy or whether it is mild depression?
Yes, ma'am. So here the patient has no feeling of hopelessness or sadness. So apathy is generally having blunt effect. There are no positive or negative symptoms in it. However, with depression, there are really negative symptoms like hopelessness, sadness, excessive crying. And so these negative symptoms will take the patient towards depression. Second is a lot of cognitive impairment occurs with apathy, so they will have other associated memory disturbances, and whereas depression will have fewer cognitive and more of affective disturbances. Also, patient will himself not complain in apathy. It will be the caregivers who will be more concerned about him, but whereas in depression it will be the patient who himself will keep on complaining. And again, depression is not progressive, whereas apathy will eventually progress like any other dementia.
Yeah, I think that's a fair range of differentiating features between apathy and depression. What is common between both of them is a lack of motivation, a lack of drive, and that is common for both. And then, as you mentioned, you can actually differentiate them based on the presence of other features of affect. But it's again important to realize that they could coexist. In many dementia syndromes, there could be both depression and apathy. And why is it important to tease out how much depression, how much apathy, whether depression or apathy, is that depression is amenable to treatment. And just because somebody has a cognitive problem, and it can get masked as just apathy. So if there is a slightest suggestion that there is some sadness in him, the sense of worthlessness, then it would be worthwhile to actually try antidepressants in such people, whereas the therapeutic strategies for apathy would be quite different. There is some evidence that methylphenidate works. So it's very crucial to tease these apart or see if they coexist and which one is more prominent. And in him, you think that it is apathy that is the prominent symptom, right? Fine.
He used to make mistakes while exchanging money with customers and would easily get distracted. Since 2 years, he goes to the shop and is not involved in the monetary matters in the shop. He can either plan trips to his native place like how he used to previously plan, like he used to himself go and buy the tickets and would take the family in the train and go to the native place. But now he cannot plan any of these things.
So what do you make of these symptoms? Which
Uh,
cognitive domains do you think are affected?
The mistakes in exchanging money and easy distractibility. So these things can be because of attentional deficit, um, and because of easy distractibility. So attention is one domain which is affected, and difficulty planning and organizing events will be towards a kind of some executive dysfunction, wherein he cannot do sequential activities of planning and programming in a manner.
So
So
goal-directed activities which require multiple steps, which are error-free. So that, and given that all other cognitive domains are reasonably preserved.
yes.
So yeah, that's fine. Continue.
There's history of forgetfulness since 3 years. He forgets where he has kept things and he easily misplaces them. He forgets if he has been given some vegetable order. However, he remembers what he's had for breakfast, who had visited home the previous day, and also remote events in his life.
So here we have the symptom of forgetfulness. So do you think this is a memory problem? How would you interpret these symptoms?
Yes. So forgetting things like immediately order that has been given to him and misplacing things, this could be a problem of attention also. So it is not specific for an episodic memory problem. In fact, this patient remembers what he's had for breakfast, who had visited him. So these episodic events of his life, he very well remembers. So this is not a problem per se of episodic memory, but it is an attentional deficit again over here. Also, the remote events are normal. So again, that tells us more that it's a more of attention problem rather than a memory per se.
So this is the thing. Patients can come to us saying they're forgetful. And when we say forgetful, they perceive many cognitive symptoms as being forgetful. One is obviously the most important cause is actually forgetting what they already knew, an episodic memory disturbance. And that history you get when they say they've forgotten that they visited somebody, or they forgot a conversation, or they actually, an important event in their life, a death of family member, they forgot. So you actually get proper history of something that they knew and they forgot. But at the same time, like in this patient, it could just be an attentional problem where they have not even registered properly what is happening around them. And then it manifests as forgetfulness, and it's usually for very immediate things. If you have a language or an aphasia, you could forget just words, and then that would manifest as forgetting names. And so the relative will come to you saying he's forgetting, and then you have to really ask, what is he forgetting? And then semantic memory problem could be forgetfulness. Prosopagnosia, I can't recognize him. So they say he's not able to remember this person's name. So in general, even agnosia is not being able to recognize objects. People would say he's forgetting how to drive a car, so how to handle objects. So I think this symptom of forgetfulness can actually can actually be an umbrella term for many cognitive symptoms. And in this case, I agree with you. It looks very attentional. He doesn't seem to have significant amnesia. Next.
There's history of slowness in all activities with left upper limb and lower limb since 2 years, with abnormal posturing of his left upper limb. He cannot use his left upper limb for any task, including tasks that require both hands to be used. However, he doesn't feel that the limb is not his own. He can use tools properly with his right hand. He dresses by self, but sometimes puts the buttons irregularly.
What does this suggest to you?
So this could either be like, one is because of the abnormal posturing and slowness. It could be an extrapyramidal dysfunction like dystonia, or it could be there could be some element of apraxia because he is not able to use his limb as well for tasks. So both the components, but it's difficult on history. So I would like to examine for that.
Right. I think sometimes not every symptom can be analyzed to its accuracy, to its most accurate nature in the history. It's fine to be open about it. It's fine to consider a couple of options, but then it's again important at the level of the examination to confirm it, not to say, however, that you have to be vague. But in this particular situation, I agree with you that there is some element of slowing and posturing, but at the same time, they say he cannot use his left hand. So this needs to be clarified in the examination or with a more detailed history if it's forthcoming. Next.
There is change in his speech since 3 years. His speech has become slow and strained. There is no reduction in the volume of his voice, however, and there's no history of difficulty naming or any language disturbances. So no naming or language disturbance.
Mainly a problem with speech, which what kind of speech difficulty do you think this is?
So this is like a dysarthria more than, it's not a language disorder, it's more of a dysarthria, and because it is more strained, so it is, so I would like to hear him exactly whether it is spastic or there is component of extrapyramidal also.
Right.
So it is mainly dysarthria because naming and language both are intact.
Next, you can move on.
There is imbalance while walking and fear of fall. He walks with a stick since a year. There's history of 6 to 7 episodes of unprovoked falls, both forwards as well as backwards, since the past 2 years. He has also injured himself. Falls occurred both outside and at home. The frequency of falls have increased over the past 6 months. There are no complaints of dizziness or lightheadedness prior to falls. There's no history of freezing and there's no history of any tremors.
So what do you make of this?
So this is again postural instability, which has come up quite early into the illness and which has caused falls. And there are no accompanying dizziness or lightheadedness, means we've ruled out syncope or any seizure prior to that falls. And these are unprovoked. So it is mainly postural instability, again, which points towards early extrapyramidal dysfunction.
Yeah. So at this point, it might be useful to talk about his gait, whether it's broad-based, whether it's narrow-based, whether he sways to one side. So look at other causes of falls, and maybe that will help us. But you can continue now.
There's no difficulty in vision except during reading the newspaper. He finds it difficult reading newspapers and frequently changes his spectacles and is never satisfied. In fact, while eating as well, he messes his clothes. There's no history of any double vision or difficulty chewing, hearing loss, or any dysphagia.
So this is something that the family gives us as a history. But when you're talking about history, one is to just recount what they tell us, but then that's just giving a history. But then our role as a neurologist will be to actually interpret the history in the words of the carer, not to use technical terms. But when you actually present the history, we have to form an image in our mind as to what could be the problem. So I'm not very clear about what kind of difficulty he has in reading the newspaper and what's actually happening here. Did you have a chance to actually talk to him or talk to the family member? And can you give us a little more information about this?
Yes, ma'am. So, she said that he is not able to read the newspaper like this. He has to hold it here, straight like this. Only then he's able to. And even while eating, he has difficulty looking down. So that's why he is not able to eat properly and messes his clothes. So I feel that this reading newspaper difficulty is not a cortical or a vision problem, but it is mainly a disorder of his extraocular movements that probably he is not able to, and also frequent changes of spectacles. So he's not able to change his gaze easily.
Right. So we are fortunate that in this patient you're getting such a good history that he's actually needing to take it upwards, and this is very classical, as you said, of a gaze palsy, vertical gaze palsy. But we don't always get this history, and it can be sometimes very confusing when you have a visual problem to find out why exactly he's not able to read very well. But I think in this case it seems reasonably okay. Next.
There's history of urinary urgency and urge incontinence. He voids on his way before reaching the washroom and is not ashamed about it. There is no history of any constipation, however.
Right. And so what do you make of this?
So this is like a frontal kind of a bladder. It's a suprapontine bladder dysfunction because there is urgency, and there is he's not even ashamed about his incontinence. So both these things point towards a supracortical bladder, frontal
Right.
dysfunction.
So we can continue.
Currently, he gets up and does his daily activities independently and with some help in dressing and grooming. He walks with support of stick. He cannot travel alone or take up responsibility of work at his shop. This is current status.
Yeah, so it's important to continue. It's important to talk about the functional status in any patient with cognitive disorders, because when you define dementia, we say it has to be impairment of cognitive functions sufficient to impair his activities of daily living. So it's, and then it's also linked to how much stress there is on the family, and you have to therefore always give a history about how it's affecting his day-to-day life. That's fine. Next.
He consumes a mixed diet. His sleep is normal. There's no history suggestive of any REM behavioral disorder. There is no family history of similar illness. No, this is his family tree. Nobody had similar illness.
So the thing about cognitive disorders is that you can have a heterogeneous presentation within the same family. So it's not sufficient to say that there is no family history of similar illness, no what with similar illness. The behavioral problems, the cognitive problems, the Parkinsonian problems, or is there some other neurological disorder that can be associated with a cognitive disorder? So you will need to give a little more detailed history about whether there was history of behavioral disorder in his family, suggestive of a frontal behavioral disorder. Was there a problem with memory? Was somebody diagnosed as Alzheimer's disease? Because it's sometimes, it's just a label given for anybody with a degenerative cognitive disorder. Sometimes just Parkinsonian syndromes can occur without cognitive impairment as part of some genetic frontotemporal dementia syndrome. So you have to ask for history of Parkinson's disease. And then ALS. Some people can have ALS, some people can have. So that's another thing. Primary psychiatric disorders. There's a higher frequency of primary psychiatric disorders in people with frontotemporal dementia. That has to be asked. In fact, there's a history of higher incidence of autism among children in families that have genetic frontotemporal dementia syndromes. And apart from this, vascular risk factors and all of that. So, and especially in the Indian context, if you ask them, is there a family history, they generally would say no. But then if you ask them, how many brothers do you have? So how is this brother and how is this sister? So you actually name them and ask them, and then they might actually remember and come out and say something. So it's very important, especially in a cognitive disorder, to spend some time on the family history. So did you happen to ask anything like this?
Like few things I could ask. Like I asked about Parkinsonism and dementia in other family members.
Right. So there's nothing much forthcoming, right?
No.
Okay, carry on.
There's no history of diabetes, hypertension, or any addictions. There's no history of stroke or ischemic heart disease. There is no history of stepwise progression. There's no history of headache, vomiting, or seizures. There's no history of hallucinations, fluctuations, change in sensorium. No history of twitching of muscles or any high-risk sexual behavior.
So at this point, Prachi has presented her history. I'm sure there are many other points in the history that one could ask for. She might have asked for it, might not have thought it's important or not found the time. So first I'll ask people in the hot seat, is there something else that you would like to know? And then I also request the audience to either raise your hands or type questions about anything at all in the history that you would like to ask. Fahim, I see that you have raised your hand.
Just wanted to know three things. Dr. Prachi, whether there was any history of lack of concern for family members, like he was insensitive to the family's needs, and whether he was verbally cruel to the relatives and friends whenever they used to meet him. This kind of history is very important. Why I'm asking, because it's a part of the social cognition. in these patients, and it is impaired in patients of dementia. Was it there?
Yes, sir. There was quite strong history which suggested that there was impairment in social cognition. So, apart from apathy, he had uh, loss of empathy in terms that, like, there was one event I remember that he said that prior to this entire episode, he was much concerned about his son getting married. But now, since the past 2 3 years, he is like ठीक है वो शादी नहीं करेगा तो चलेगा, it's okay even if it doesn't get married. So he is not really bothered about finding a suitor for him and is okay with the fact that he's not married. So that one thing is, it points towards his lack of empathy towards his family members. And yes, so that is one thing.
Then what about, did he have any right to left confusion? He was wearing slippers in the wrong feet, right in the left, left in the right. And did he have any difficulty in writing? Because that history was not there, that's why I'm asking.
Yes, yes. So there's been a change in his handwriting. He has difficulty in writing, and we cannot make out what he is writing. But there was no history which was suggestive of any difficulty wearing chappals or any confusion with his orientations of right left.
Then last question, whether he had difficulty in recognizing faces of his relatives and friends, and whether he had difficulty in recognizing objects. He was handling one object for the other, because this history is important for visual agnosia, because it didn't come up in the history. That's why I'm asking.
Okay, sir. Sir, he did not give any history as such that he had any difficulty seeing objects around him, and he could actually make out the day-to-day objects that are there around. So neither did he have difficulty recognizing faces of people. That history was not there.
Anything else?
Uh,
Yeah. So this is it's very important to ask about social cognition. It's now part of DSM-5 criteria, and as Dr. Fahim has mentioned, you have to make a special effort to ask. It's relatively new, but it's a very important cause of distress to family members, and that should be incorporated into history. Similarly, focal cortical syndromes, Jasmine syndrome, visual agnosia.
Ma'am, we have a couple of questions actually.
Yeah, I can't see the questions.
We also have 5 people who have raised their hand. Do we want to?
Yes, absolutely. We want every question, but I cannot see any of the questions.
I can see all the questions, ma'am. Should I read it?
Yeah, you can read out the question.
What I'm saying is, do we take the questions first, or do we allow people to talk first?
Anything is all right.
Devashish, what do you want to do?
Whichever is shorter, we'll do first, and then we can.
Let's take the Q&A first then.
Yeah. So we can unmute and ask them. Let them ask the questions first. And
okay. All right. Fine. Then I'll allow people to talk.
Yeah. Please introduce yourselves.
So the name is Vivo1951.
Please write your own.
So what we can do is we can probably allow the people who have put their names to talk.
Yeah.
Yes.
Yes. So Dr. Blessy and Dr. Chandrakant.
Okay. Meantime, the questions are, Madam, can you please comment on the gait of this patient? So what was the gait?
Yes.
Okay. Yes, so we have a video of his gait later on, which is coming up. But so this patient had he got up without making any postural adjustments. He had a wide, broad-based gait, and he would pivot on turning, and he had a dystonic posturing of his left upper limb when he was walking, and there was some amount of retropulsion as well. So there was definitely dystonic posturing and straddle toe as well when he was walking. Gait was extrapyramidal with decreased arm swing on one side. We have a video also coming up.
Right. There is one more question. If there is any history of wandering or getting lost in known or unknown places?
Yes, actually, there's no such history of getting lost in familiar or unfamiliar places. I didn't mention it, but yeah, that history was not there.
Yeah, Dr. Pramod Donde has asked, apart from activity of daily living, will it be important to ask IADLs as instrumental activities of daily living?
Um,
So what are the instrument he used to use? And
yeah,
then
so so even handling money and like his activities like handling money and planning trips, these are also instrumental activities of daily living. So it need not be that only brushing and taking grooming and taking care of himself. These are the basic activities, ADLs. So instrumental ADLs were also impaired in this patient, and that history is like how difficulty he has in traveling or in handling money or in like
right.
dealing with
Yeah.
opportunities.
Yeah, and it's a very, very important question, because now we are seeing people in very early stages of disease. We're seeing people in stages of mild cognitive impairment, and you see high functioning people. If it's a judge who's sitting on some important judgments, for him, instrumental activities or daily living are actually pronouncing the judgment. So it will vary with person to person. So I think it's a very, very valid question. And we tend not to give this history, and I think we should really devote more time into what kind of occupation, what kind of social interaction, what responsibilities. And as neurologists, if we have to ask these questions, because we'll have to finally counsel them, and also helps us to make a diagnosis, whether it's in the early stage of dementia, whether it's MCI, whether it's subjective cognitive memory problems. So a more detailed history on IADL and ADL would definitely be useful.
Dr. Sandhya Manojan has asked, Prachi, you have described that the person was not able to control his left hand, but from history, can you think it is alien hand, and how you will differentiate alien hand and apraxia, and how to differentiate in between these two? So the differentiation between alien hand and apraxia from history.
Yes, sir. So for alien hand, actually, so there are types of alien hand, that is frontal and parietal. So even things like groping behavior that can occur in frontal alien hand. So if the hand just goes around and tries to grab things, that can be indicative of a frontal alien hand. Another is obviously intermanual conflict, which is callosal, again frontal variant. So if any history of intermanual conflict, like he has difficulty in doing bimanual tasks, that can again point towards alien hand. And uh, uh, thinking that the limb is not his own and it has a mind of his own. So if patient comes out with a history that it's not following my orders and it is just acting in its own possible way, that will again point towards strongly for an alien hand. And this kind of thinking that the mind is on mainly seen with parietal alien hand, and things like apraxia are associated with alien hand phenomena. So that is one thing. But with dystonia coming into the picture, we have to actually test for apraxia and then say whether it's actually apraxia or it is dystonia only.
And last question from the all the students are, he is making mistakes while calculating money or money handling. Whether do you think it is as a part of calculation problem or as an executive function problem, and how you can differentiate between these two?
Will I take that?
Yes, ma'am, please.
Okay, you can drink some water in the meanwhile. Okay, so we can, yeah.
Sure.
So any symptom can be caused by involvement of multiple cognitive domains. Like I mentioned, forgetfulness could be memory, could be attention. Similarly, for specifically making mistakes with money, could be a host of. It could be the fact that he can't recognize the money. It could be an agnosia to paper money. It could be problems with calculation. It could be a left parietal involvement, and he actually has problems with calculation. It could be an attentional problem. It could be a executive dysfunction. It could be working memory problem, where he's not able to hold the information. And typically, among all of these, if it's making mistakes in exchanging money and giving change, we would like to think of a working memory problem, because you have to remember that, I've given 20 rupees to him, or somebody's given me 20 rupees, and I have to give back 10 rupees. So I have to hold the number 20 in my head and then return 10 rupees, which is like the 100 minus 7 or 20 minus 3, or spelling the word world backwards, or it's like digit backward. So all of these are working memory tests, and it's a very frontal, and then depending on if it's a verbal information, it's left temporal, and if it's a visual information, it's the right parieto-temporal. So first, and any symptom has to be placed in the context. So if you find this symptom, you have to ask, is he misplacing objects? Is he walking into rooms and forgetting why he's come there? Is he forgetting immediate conversations? And then you say, okay, then it must be an attention working memory problem. If there are other parietal lobe signs then or symptoms, then you say, okay, maybe it's part of acalculia. And then if it's part of a larger attentional dysfunction, then you say maybe it's attentional. So you'll have to ask for more history to actually focus and say this is the reason. There are some other questions here which I'll quickly read out because I think they're all very, very good questions. Can sundowning differentiate apathy and depression? I mean, many of these questions really don't have definite answers, and I'll just quickly run through them. That each of them is a research question in itself, and I'd encourage all of you to pursue this one question in the next 15, 20 patients that you see. Typically, yes, depression, sundowning is a problem that you see with neurodegenerative disorders. I'm not so sure that apathy worsens with time in the evenings, but it's more a behavior that can get worsened, positive behaviors that can get worsened in the evening. If there's anybody in the audience that can answer this question better than I can, please volunteer. Vireshma, Fahim, anybody else? Then gait is done. Hoarding behavior, very important in the negative history. So along with food faddism and utilization behavior, one has to mention hoarding behavior, and you have to ask specifically. Patients don't come out and say because they don't think it's a neurological symptom. And then you ask them, does he collect objects? And then little embarrassedly, they will say, yes, he actually collects papers, or he collects idols, or he collects bottle caps. So they won't tell you in the beginning. So you have to give them the space to ask, to tell you this. And generally people are embarrassed about these behaviors, so they don't share easily. Then what is the history for social cognition? Dr. Fahim mentioned there are 3 things in social cognition: difficulty in recognizing emotion, problems with empathizing with the people, and understanding what the other person's perspective. Typically, it's about, he doesn't care for me anymore. I got a good job, or I did very well. He didn't display any happiness, or he was very cruel to me. He said very hurtful things to me. So these are some of the things for social cognition. Utilization behavior, very important again. Is he picking up objects? I should mention the names of people who are asking. So Rayini Murali is asking about utilization behavior, and that is very helpful in diagnosing frontotemporal dementia syndromes. Social cognition is somebody called JB. Praveena asked about hoarding behavior. Sundowning was asked by Nikhil. Thank you, Nikhil, for that question. Any more questions? Sashi Jaiswal asks, can we differentiate between stepwise progression versus subtle progression? If it's a severe symptom that has come suddenly, like in stroke, yes. So typically, yes, you can differentiate. But if the history is very long-standing, the caregiver is not very knowing, sometimes they may not be able to recall whether it came suddenly or not. So important to keep in mind. Praveena asks, is there difficulty in getting dressed? She did mention, Prachi mentioned this. There was some clumsiness, but nothing much, right? There's a question iPhone has asked on category fluency and semantic fluency. We'll come to that in the examination. Okay, so Shreya asks, do we consider cerebellum as involved neuraxis here in view of imbalance and strained speech? And this has to be resolved at a level of history. And Prachi mentioned that there was no wide-based gait, not walking like a drunken person. So gait does not look cerebellar. Strained speech, dysarthria always examine. Was there change in food preference? Atul Jadhav asks. Prachi mentions no. Okay. Shailesh again asks types of wandering, localization of each. Now this patient did not have, we'll probably present a parietal case, or somebody else will present where we can discuss this, running out of time, but frontal wandering is very utilization type, they go out and they don't get lost, but they're compulsively going out and wandering, whereas more parietal type behavior is losing way in familiar places. Maddie asks, do we need to tell in detail about premorbid routine? Yes, very much so in cognitive neurology. Maddie also asks, were there sensory symptoms in history? Prachi, were there any sensory symptoms?
Sensory symptoms.
Okay. JB asks a very important question. This posturing, was it levitation or was it dystonic posturing? I actually wanted to mention at that time. So posturing could just be levitation. It not even need not be dystonia. So we will know when we examine the patient. Any Shashank Jaiswal asks, any history of religious fanaticism, hyper-religiosity, delusions, hallucinations? Very important. You did not mention delusions, hallucinations. So,
Hallucinations.
you did? You did?
Yeah, no negative history. I mentioned no history of any hallucinations or delusion.
Yes.
Religion.
Narayan Deshmukh asks, is there any history of taking drugs for any of these treatment, for any of the symptoms before this interview? Very important. Why? Why do you, Prachi, you want to take this question? Is there any history of taking drugs for any of the symptoms? And then why would it be, how would it help you?
Yes, madam. Anticholinergic drugs, especially when if taken for Parkinsonian symptoms, will worsen the dementia and also the urinary symptoms that he has. Then if he has taken benzodiazepines, that will again worsen dementia, even antihistaminics. So a lot of drugs which are used for extrapyramidal, even for his irritability, if somebody has given him antipsychotics, and that can also worsen the dementia, especially the typical ones. And also they carry higher mortality in dementia patients. So that needs to be taken care of.
Yes, very good. Drugs that cause cognitive impairments, drugs used to treat behavioral problems that worsen extrapyramidal symptoms, drugs used to treat cognitive symptoms that might worsen any of the behavioral symptoms. So these are some of the things. Hyper-religiosity, any hemi-neglect, did you mention? Abhilash asks, anything to suggest hemi-neglect? What would you ask? What history would you ask for hemi-neglect?
So there is this personal hemi-neglect and there is environmental neglect. So for personal, I will ask whether while shaving, does he not shave one side of his face, or while grooming, he is not bothered about dressing up on one side. And for the environmental neglect, I'll ask whether while eating, does he eat from only one side of the plate and he just leaves the other side, or while talking in conversations, is he bothered about one side and or he's not. While writing, is he writing from one side, or he's just leaving a huge gap on the left side. So that these history, personal as well as extra personal neglect history that we can ask.
Yes. So Dr. Reenu Chaudhary asks, the reason I'm taking more time for the history is diagnosis and cognitive disorders is made at the level of history typically. So we can spend a little more time on this. So Dr. Reenu Chaudhary asks, emotional incontinence versus behavioral change. And also how to differentiate between apraxia and executive dysfunction. Prachi, you've been doing well so far. Why don't you take this question? You can try. Emotional incontinence versus behavioral change. I think emotional incontinence is a form of behavior. There are many kinds of behavior. And as I said, irritability, aggressiveness, agitation are non-specific. But other behaviors are very specific. Frontal disinhibitive behavior, hoarding, all of that. Emotional incontinence is a behavioral change, so it's not a versus behavioral change. But what does emotional incontinence suggest, Prachi?
It suggests subcortical involvement, like it's mainly seen with ALS and things like that.
Another question, how to differentiate apraxia from executive dysfunction? Actually, the reason there's a confusion is because the way we define it, but actually in real time, it's not such a difficult thing. Apraxia is, you want to take it, Prachi?
Apraxia is defined as difficulty in doing skilled activities, learned skilled activities in the presence of intact motor, sensory, and other cognitive domains. So patient, so he's not able to perform the learned skill activities in spite of intact cognition. And in executive dysfunction, he just doesn't know the sequences, like how he'll proceed. So the cognition itself is affected, like the in executive dysfunction, the how do you call it? He just doesn't know how to go about with the next step. But in apraxia, he knows it, but he's not able to perform it. It's a learned activity which he cannot do.
So that is the theoretical basis, but we are interested in the patient. We are interested in the history. So we have a patient who can't make a cup of tea. The wife will tell, or the husband will tell you, she's not able to make a cup of tea. So how would you differentiate? Is it executive dysfunction or apraxia? See, apraxia is clearly a disorder of skilled motor movements. It involves interaction of the body with a tool, with some material. So how she holds the cup will be impaired. The grasping movement, the reaching movement, she will hold the cup like she's not supposed to hold it. She might hold it from the opposite side or from underneath. So that is apraxia. It's clumsy when you're performing the activity. But the sequence itself may not be affected. So the cup and the water and the milk and the sugar, the sequence may actually be all right. But every action in the interaction with the tool will be clumsy. That is if it's ideational, that is if it's ideomotor apraxia. If it's ideational apraxia, she would have forgotten the motor engram is lost, so she would have forgotten the steps. So she will not be able to do it. On the other hand, if it's executive dysfunction, there are three things: focused attention, ability to shift from one step to the other, and reaching the goal without errors. Now, this is impaired in executive dysfunction. So what will happen is she will hold the cup properly, she will hold all the objects properly, but she will do one thing before the other. So she'll make a lot of errors, lot of self-correction. So she'll take a long time to do it. So on the surface, not able to make a cup of tea, very slow, but with apraxia, it's clumsy, not holding the tools properly. With executive dysfunction, it is frequent errors while performing this. And this is something that you have to take a history. Cognitive neurology is only learned by taking history and analyzing it yourself. So the more number of patients you see and the more you analyze, the easier it becomes to understand these phenomena. So I think we have reached, okay, Priyank Patel asks, is there history of perseveration? So, Prachi?
Not historically, there is no perseveration. Like he doesn't
Right.
keep.
And then Manoj Vasireddy asks a very relevant question. In apraxia, is it necessary that all other cognitive domains should be normal? This has been the frequent source of much disagreement in many classes across the world, maybe in the country, when the movement disorder specialist will say that there is dystonia, so it cannot be apraxia, and the cognitive neurologist will say, but he's not able to do something, and it's more looks like a cognitive problem. So in the definition, yes, they should. It's not should be normal. I mean, the impairment in motor, sensory, or cerebellar should not come in the way of performing that activity. I think if there's a disproportionate difficulty in doing the activity, which is out of proportion to their motor or sensory or cerebellar system involvement, then you will consider apraxia. So yes, it has to be out of proportion to any other deficit. So I hope that answers the question. So oh my God, there's one last one. Right. Smita Chandran, in research criteria of FTD, Reskovsky, Katia Reskovsky's criteria, one criteria for possible FTD is early apathy or inertia. What's the difference? There is no difference. I think at this point, we can consider them to be similar, mean the same thing. So we're done with all the questions. So back to, so what do we do next? The raising hand, right. Great. So now, Prachi, you want to continue?
So to summarize, it's a 57-year-old male with 3-year history of insidious onset, gradually progressive behavioral changes in the form of irritability, apathy, loss of empathy, and disinhibition. Inattention, probable executive dysfunction with relative preservation of memory and language, and 2-year history of asymmetric bradykinetic syndrome with left upper limb dystonia, useless limb query-apraxia, and early unprovoked falls with spastic dysarthria and urinary incontinence.
And that covers everything. Next.
So the domains which are affected are for behavioral disturbances, it is the apathy, disinhibition, and impaired social cognition, inattention and executive dysfunction, asymmetric Parkinsonian features, postural instability with, as per the history, some vertical palsy and query apraxia.
I think that is quite comprehensive. Next.
So the site of localization.
Yeah. So this is very important because the pathology and where it starts and how it progresses is going to give us the diagnosis. And this requires a very deep understanding of brain anatomy, functional anatomy. So I would like to ask Dr. Reshma, who has to unmute herself. She has just finished her neurology exam. She's a neurologist now. And I think the right person to tell us how you would localize these cognitive domains to different parts of the brain.
Yes, ma'am. Good evening, everyone. The first set of symptoms in this history are related to disinhibition, like the behavioral changes, verbal cruelty in the form of swear words, and then there is this bladder disinhibition and excessive eating. So all these point towards disinhibition, and disinhibition will localize to the orbitofrontal cortex and its subcortical connections. So that is the first set of symptoms. And the second set of symptoms are loss of interest. And there is history suggestive of apathy as well as loss of empathy. So these two features, they are strongly suggestive of involvement of a medial prefrontal cortex and its subcortical connections. And then there is a history of excessive inappropriate laughter, which means there is some involvement of a pseudobulbar pathway suggestive of the corticobulbar tract involvement. And then there is this history, after 1 year, then there is this history suggestive of difficulty handling money, and which suggests a problem with, I would like to consider here the problem with executive dysfunction or attention more than calculation. And also there is a problem with the planning, where Prachi mentioned about this inappropriate planning about the trips to native places. So planning and other money handling problems could be most likely related to his executive dysfunction, working memory, and attention. And all these, and that forgetfulness, I would like to take it more like a problem with the working memory than memory impairment. And attention and executive dysfunction. So all these will localize to the dorsolateral prefrontal cortex and its subcortical connections. And then in the sequence, we had the involvement of, there was bradykinesia. It was asymmetrical bradykinesia. And this will be localizing to the direct pathway in the extrapyramidal system. And then there was history of abnormal posturing of left upper limb and inability to use the left upper limb. So at history level, it might be very difficult for us to be sure whether it is a dystonia or apraxia. So I will just keep it open. I would like to examine, and then we can probably comment. If it is a dystonia, it is related to the basal ganglia and its circuits. And if it is apraxia, and it is the dominant hand apraxia, so it will be the parietal involvement. So, and then there is change in the speech, and the quality of the speech given here is slow, harsh, and strained. So all these pointers are towards a spastic dysarthria. So the corticospinal tract involvement. And following this, there was a problem with imbalance. Patient is having unprovoked falls backwards and forwards. So these unprovoked falls might be related to the loss of the postural reflexes. So it will be related to the labyrinthine, the other visual reflexes, which are responsible for the postural reflexes. The writing reflexes and the postural reflexes are responsible for falls. And then all these are the point, and whatever bladder symptoms Prachi has mentioned, they are pointing towards the frontal bladder, Bradley loop foray. So at the end of this, I can tell that there is involvement of the frontal cortex and its subcortical connections, which started off like the orbitofrontal cortex, followed by the medial frontal as well as the dorsolateral prefrontal cortex. And then there was corticobulbar tract involvement, corticospinal tract involvement, and there is involvement of the direct pathway in the extrapyramidal system, as well as the basal ganglia and its circuits if we consider dystonia. So these will be the anatomical substrates of what Prachi has given the history to us.
Yeah, and so there is parietal also.
Yes.
So that was an excellent description of the brain areas. What is also important to see is what areas are not affected. So which now you're in the hot seat. We haven't practiced this. So which areas are not affected? Reshma, Prachi, Fahim, anybody?
Yes. Okay. So here the occipital lobe is not
She's
affected.
trying to say something, Reshma, but she's mute. Reshma, you're muted. Reshma, you're muted. Reshma, you're muted.
Mute.
So I think it is predominantly frontal.
Now you start again. We couldn't hear anything. Say.
Oh, I'm sorry
Now we
about that. I'm sorry about it. So in the history, whatever Prachi has given us, there is preservation of memory, and whatever visuospatial as well as, visuospatial domains of cognition were preserved. So now there is currently not much involvement of the temporal lobe, as well as parietal is plus minus because we are not very sure about the apraxia, but occipital and temporal lobes, we can say from the history that they're not yet involved. So parietal I would consider. Yes.
So I agree completely with you. Medial temporal lobe is not affected as of now because episodic memory is preserved.
Yes.
There is history to suggest apraxia. There is, in working memory disturbances, attention is not just frontal, it could be frontoparietal. I would say there is some evidence of parietal involvement already, but medial temporal is not affected. The other localizing symptom is for empathy, it's frontoinsular structures. So it's for social cognition is very frontoinsular, frontotemporal. So that's an area that is involved. So this is some pathology that is involving, as you mentioned, these areas, but sparing some specific areas as of now, and I think that's very important. Right. So shall we, do you agree with her, Prachi?
Yes, ma'am.
Right. Go on.
So the differential diagnosis I would like to keep is first frontotemporal dementia Parkinsonian syndrome, and second is an overlap FTD syndrome. However, I would like to rule out secondary causes like any slow growing tumor, meningioma, which are treatable, and vascular dementia and Aguilon 5 encephalitis, because sometimes even that can present as a extrapyramidal dementia, slowly progressive syndrome.
Right. So the question is really, is it a typical frontotemporal dementia with behavioral problems, disinhibition and Parkinsonian features? Or is there something that will tell us that it's more than a typical behavioral variant frontotemporal dementia? Because you have early unprovoked falls, you have some features of, so which are the overlap syndromes that you are thinking of that are overlapping with behavioral variant FTD?
So there can be an overlap of PSP.
In this patient.
In this patient, there is, because of early falls, I would like to keep PSP quite high on cards. And second is the asymmetric posturing CBS, a corticobasal syndrome. So like an overlap of FTD, CBS and PSP,
like we don't know what we are talking about.
Like a tauopathy kind of a thing that we'll have to look up.
Yes. So we are having symptoms, features of 2-3 different syndromes which we think are separate, and we're having features of all. So sometimes this is what I meant, but they don't read the textbook, but we really need to confirm on examination. Is it a secondary cause? It's very long history, and there are no vascular risk factors. There is no features of raised intracranial pressure. It's very diffuse. It's both frontal and parietal, but very often we've been surprised. And it's very important in every patient of dementia to consider secondary causes, regardless of how typically degenerative it looks. And we're getting more and more evidence that autoimmune disorders can also mimic dementia syndromes. So therefore, secondary causes is very important to look for in them. Yeah, so continue.
So,
That's fine, move on. I
yeah.
think we can.
So on examination, patient is conscious, his vitals are normal. He studied till 5th standard, he is right-handed. While testing, he had some inappropriate laughter. His MMSE was 22. He lost points in orientation to time and place. And his registration was normal, but his calculation was 3. He lost points there. And in recall, he lost 1 point, but with cues, it was again normal. His language was normal except for writing, where he made mistakes, and also copying diagrams. So there was some visuospatial problem as well. Like, yeah. So, sorry. So his digit span forward was 5 and backward was 4. Days in week forward was 7 and backward was 7, and months forward were 10 and backward was 0.
So just what does it mean when a person can, give days of the month forward, but just cannot do anything backward? Which domain do you think is affected?
So it's working memory which is affected.
Yeah.
Backward
Very
span. Language, his language was normal except for reading comprehension. Paragraph was impaired, and his writing was grossly impaired. All spontaneous writing on dictation and copying, all 3 were impaired.
Do you have a sample of his writing?
Yes, ma'am.
And can you, because you watched him write, why do you think he wrote like this?
See, he was not able to hold the pen quite properly. So dysgraphia component could have been.
So dysgraphia due to, I think you think it's more, do you think it's a dysgraphia? Or do you think it's apraxia and he's making these errors? You can see he's scratching out so many times and the words are not formed properly. So is it grammar? Is it spelling? Is it spatial problems? Or is it just the fact, a motor problem of writing with the pen?
It's just the motor problem of writing with the pen. Apraxia, because otherwise his grammar when he was talking was absolutely normal. His spontaneous speech was normal.
Writing, you can have dissociation between writing and speaking. He's striking out so many times.
Yeah.
It's almost like, so sometimes watching a person do an activity can actually give us more information about this. Continue.
On memory testing, his episodic memory, recent memory, verbal, 3-word recall was 2. Okay, with cued was normal. And what did he have for lunch was, he could say correctly. His visual recall was again normal. His remote memory was normal. Semantic memory was also normal, like naming and describing the use of pictures of 15 common and uncommon objects. His category fluency was quite good. 14 vegetables he could name and 10 animals. So his trail A and trail B tests, they were both impaired. So
do you want to explain these tests?
Trail A is a test which is done for attention and trail B is done to check for executive dysfunction. So if these are impaired, they point towards a dysfunction of attention and
so trail A is just connecting numbers 1, 2, 3, 4, 5, 6, 7, 8. So it requires just focused attention. You have to reach from 1 to the last number. Trail B is you alternate numbers and alphabet. So 1, A, 2, B, 3, C. So you have to hold information and shift sets. So in addition to focused attention, you need to shift sets and you need to inhibit the alphabet when you are trying to go to the number. So it also tests inhibitory control. It's goal directed. And this is a classical test of executive dysfunction, which can be done. It's a timed test. So you look at, are they making mistakes and how long are they taking to do it? Continue. It's clearly impaired.
Yes. So copying the loops, 3 loop, he was, there were mistakes here again, mistakes of executive dysfunction, of planning and monitoring the activity, and also some perseveration that we can see.
Continue.
Utilization behavior was, however, absent. His abstract thinking and judgment was impaired. His insight was absent. His primitive reflexes were present. Like palmomental was present on the right side, pout and glabella tap was present. Stroop, he scored 2 out of 4, so that was again impaired. His applause sign was positive. And on frontal assessment battery, he scored 4 points out of 18. Lost points in similarities, lexical fluency, motor luria only 1 point, conflicting instructions and go no go again, and prehension was normal. And here his category fluency was, however, preserved. So lexical fluency was 0 and category fluency was pretty good.
We had a question after history, category fluency versus lexical fluency. Do you want to talk about it?
So lexical fluency is mainly impaired with frontal disorders, and category fluency is mainly impaired in medial temporal disorders. It's a problem of it's about the frontal filing clerk and the filing cabinet. So when the filing clerk is at fault, then the lexical fluency is impaired, and whereas when the cabinet is impaired, then the category fluency is impaired. So these tests will help us differentiate between the two, which exactly, because both of these can cause impairment in like fluency, but then
Yes.
which exactly?
Absolutely. I mean, I like your analogy. It's not medial temporal, it's lateral temporal, the category fluency. It's more concept, semantics, and letter fluency is more phonological retrieval. And this dissociation does indicate that there is more involvement of frontal lobe in comparison to temporal lobe. It's a good sign. Next.
On parietal lobe testing, his construction was impaired, but not that bad. But clock drawing was clearly impaired. So here he made errors in all errors, like in starting the task, only the numbering was wrong, the maintenance was wrong, and there was a lot of perseveration. He actually made 3 hands in the clock.
Continue.
His dressing was normal, line bisection test was normal, and line orientation was normal. No right-left disorientation or finger agnosia. So his visual perceptual functions were normal as well. His vision was normal, color vision was normal, face recognition was normal. There was no symetrognosia, no optic ataxia, or oculomotor apraxia.
You can present quickly so that we have time later for discussion.
Yes, ma'am. So on apraxia testing, there was impairment in like pantomiming transitive tasks with the left hand, and there was impairment with imitation of meaningless gestures, and there was limb kinetic apraxia. So
this is where we will be able to differentiate between dystonia and presence of apraxia. So let's watch. You're asking him to comb his hair?
Yes.
He's using his hand as the tool. Now this is transitive gestures, where you actually give him a tool to do the same activity, and they're generally better when they use a tool, and you can see that he is indeed much better. But on his left side, he's a little more clumsy than on the right. So transitive gestures are all preserved. Intransitive is using his hand as a tool. And here you're asking him to?
I'm asking him to imitate my.
So you can give a verbal command, you can give a imitative command, and you can see. So there are different kinds of errors that one can make. Spatial errors, where the hands are not maintained in space, the temporal errors, sequencing errors, content errors, where they don't do it properly. So you have to really describe the kind of errors that they are making. And it's clear that he has... so what kind? Okay, continue.
So here we can also see his gait. So when he gets up, he doesn't make any postural adjustments.
There you go. So you could see briefly, he brought that hand up.
Yes.
That looks like levitation.
His arm levitation, decreased arm swing, and left-sided dystonia.
Right. Continue. Right. So that was, she completed her examination. People in the hot seat. Any other things she should have tested?
I think one more test for social cognition, especially because as it's a newer component in the DSM-5 criteria, and it has three things in it: that empathy, so, emotion recognition, and theory of mind. One simple bedside test for emotion recognition would be a pictures of facial effect, just showing emotions like happy, sad, fear, disgust to patients. It will help at least in knowing what kind of impairment these patients have, because it's a simple bedside test which we routinely never do. And it has been seen that this test is impaired in patients of dementia, especially FTD. And in these patients, you'll see that they only are able to recognize happy emotions compared to the emotions. So it's worth doing at the bedside, at least to know what kind of impairment these patients have.
Right.
I think it's very important because I agree completely. And when the family member sees that he can't recognize that the expression is happy or sad, they immediately realize like they can't recognize a pen or a pencil, that they can't recognize the emotion. And then the stress comes down when they don't share their emotion. So it's also very useful for us to demonstrate to the carer that this is part of the disease.
Right.
Move on.
Thank you. Yeah. So cranial nerve examination, the first, second nerves are normal. His third, fourth, sixth examination. Fixation, there were square wave jerks. Saccades was slow. Vertical gaze, both up and down, was restricted. Vertical O'Kane was abnormal. Pursuits were normal. VOR was normal. So that says that it's a supranuclear palsies. Rest cranial nerve, 7, 8, 9 was normal. 10, there was dysarthria, spastic dysarthria, but gag was normal. And 11, 12th cranial nerve examination was normal. On motor system examination, his nutrition was normal. There was rigidity, axial rigidity present, and dystonic posturing of the left upper limb, left striatal toe. Power was normal. Sensory examination was normal. Cortical sensations were normal as well. His reflexes were brisk biceps and supinator on the right side. However, plantars were flexor, and cerebellar examination was normal. Extrapyramidal examination, he had a mask-like face, staring look, frontalis overaction, and a decreased blink rate. There was hypokinesia, which was present bilaterally, left more than right, and there was axial rigidity, no tremor, and there was dystonia, which was present, and a positive pull test. This gait, we've already seen that there was a wide stance and short shuffling, pivoted on turning, arm levitation, left dystonia, and a reduced arm swing. To summarize, 57-year-old male with a progressive neurological disease of insidious onset and gradual progression, with features of frontal behavioral disturbances, inattention, working memory impairment, with executive dysfunction, dysgraphia, visio-constructive impairment, ideomotor apraxia, left more than right, features of asymmetric akinetic rigid syndrome with left upper limb dystonia, supranuclear vertical gaze palsy, early unprovoked falls and postural instability, spastic dysarthria, and urinary incontinence. So my diagnosis is first out.
Wait,
Yes,
go to the localization.
Yes.
Yes, back to Reshma. So you localized at history. So was there anything more? Were we wrong in some place?
We were, whatever in history we thought about the involvement of the frontal, different frontal circuit subcortical connections, we had them all involved in the examination, ma'am. We had a doubt with respect to dystonia and apraxia. That we have confirmed on examination that there was apraxia bilateral, and there was also dystonia. So apraxia is more on the left than on the right, so it is bilateral. And whatever Prachi has told, it is suggestive of an ideomotor disconnection apraxia, where we don't have the translation of the motor programs into, motor engrams into programs and then their execution. So if it was callosal, it would have been more on the non-dominant limb more than the dominant. But our case, it is more on the dominant side. So whatever we have, we had a doubt with respect to the gaze palsy also, where that reading in the book, as well as that spilling of the clothes, we did not give that much of a weightage to this particular symptom. But I think from whatever examination we have done, we got a supranuclear gaze palsy. And So that is suggestive of a vertical gaze palsy. So that one history was extremely important, which was not very, very forthcoming when we took it from the patient's attendant. So this is one additional thing. So I think whatever history we had, after the examination, we have confirmed the structures involved, and we additionally got information with respect to apraxia and dystonia.
Very nice. Diagnosis, Prachi, finally?
Yes. So the diagnosis is behavioral variant FTD, PSP, and CBS overlap. However, still to rule out secondary causes like a slow-growing tumor, meningioma, vascular dementia, or Agilon 5 encephalitis. This can be done via MRI. So I would like to proceed further with my investigations.
Okay, so we have 5 minutes, so I don't think we will do this. Just a
Can
brief.
we take a few questions?
Yeah, I think we should take questions.
Now, one of the
But I just like to mention one thing, that while it's very nice to localize to a particular area of the brain, it's becoming increasingly evident that there are networks involved, these areas are connected, and that's why there is dysfunction. Pathology also spreads through these networks. So there will come a day when, at least now, it's in fashion now, whether it stay the test of time, we don't know, but today, with all these functional MRI studies that are happening, we need to make a diagnosis based on networks involved. So that's something that we could discuss at some other point. Move on. Questions? You think we should take questions now?
There are a few, madam, clinical questions.
Right. Okay.
Now,
fine. Anyway, right.
If there is impaired attention, then how reliable is detailed higher function examination? How much of impairment of attention, madam, you should
Shall I take this, Prachi, for want of time? You can always, so when there is, it's a very good question, and it depends on how inattentive the person is. If it's like delirium and the person is extremely inattentive, all cognitive functions will be affected, and you can very, very convincingly say that it's impaired attention, and therefore I would really not like to comment about other cognitive functions. But having said that, you don't get an ideal patient. In this patient, digit forward and backward is not bad. It's 7 and 4 or 6 and 4. And so there's adequate attention to do the tests. So in this patient, he's fairly attentive. There is inattention in his day-to-day life. It's evident on the tests, but it's not severe enough to come in the way of all his other domains. You have to go case by case. But in this patient, I would say that attention is not interfering with testing other cognitive domains. It might differ in different patients. Then, shall I quickly look at the questions?
Madam, there is a question of was the FAB done in this patient?
Was it done? Frontal assessment battery? Yes, it was done.
Okay.
Then, what is ideational apraxia? So ideational apraxia, you want to take this, Prachi?
Ma'am, you go ahead.
Okay, so we can't cover everything in one case discussion. There are very good review articles, but ideational apraxia is a concept of learned scale movements. Ideomotor apraxia is actually executing those movements. Ideational apraxia localizes to the dominant parietal lobe. And in addition to not being able to perform activities, it's a conceptual apraxia. They won't be able to recognize an activity. So when you do this, they may not be able to know that it's like saying bye. They may not be able to recognize tools. So it's a core engram of the action that is impaired, and it localizes to the left dominant parietal lobe. What all domains are Kushal? This question by Nikhil, so that's a good question. Kushal Agarwal asked, what all domains are checked in eclog drawing? Executive dysfunction, attention, visuospatial functions, perseveration can come up, neglect can come up, writing can come up. What's diagnostic apraxia? There's nothing, I don't know any diagnostic apraxia. Anybody diagnostic apraxia? Vertical gaze palsy was confirmed on examination. Rahul Chauhan asks, yes, it was. Applause sign, what instructions? I think we can read Dijong for this. And you want to tell, Prachi? We'll take the question. How did you give instructions for applause sign?
I just did this 3 times and asked him to do the same thing.
And then what happens?
And then he kept on doing it continuously.
Right. What all abnormalities can we expect to see during testing graphic luria? Graphic luria is that idea.
The alternate triangle and square test.
So it's perseveration, right?
And perseveration, monitoring, maintenance, all these things we can see. If he's not
Isn't it that pull test is no more done? I'm not aware of this. Rahul Chauhan asks.
sorry, which one?
Reshma, isn't it that pull test is no more done? Reshma, we don't do pull test?
Ma'am, we even in UPDRS part 3, we do have this pull test, and the criteria which are there, especially the Hoglinger criteria for PSP, in that also based on this postural instability only we give that category. So I am not very sure, but whatever I know, I think it is done as a part of UPDRS part 3 and also as a criteria for PSP where we use the Hoglinger's criteria. I think it is required as far as I know, ma'am. I'm not sure.
Right. Okay. Then callosal apraxia you have mentioned. Okay. Sripad Pujari asks, he has vertical gaze palsy. This is an important question. While giving diagnosis, should we say, yes, behavioral variant, should we say behavioral variant of PSP rather than behavioral variant FTD? You want to answer this? We reached the last 1 or 2 questions, so it's fine.
So when it is PSP, it does not begin, the patient in this case began with a behavioral syndrome, and after a year of that severe behavioral impairment, then he developed PSP. Whereas patients with PSP, they may have some amount of cognitive impairment, but it is not to begin with, and it is not of this severity to begin with. So,
right.
So the pattern, the tempo of illness was, to begin with, it was a behavioral syndrome, and then he developed features of extrapyramidal. So the tempo of illness points towards BVFTD and overlap syndrome.
Because there are only 2 more questions, I'll ask the questions. Attention and comprehension, if both are involved, how to examine? You cannot examine. If a person cannot comprehend, difficult to examine. But even in aphasics, there are certain things you can do by non-verbal gestures that should still be done. Tower of London test and Stroop test, their test of executive dysfunction, cognitive control, and she's shown that she's talked about the Stroop test. So we've reached the end of the questions. I think very quickly we'll go to the MRI, and then I think one final slide on.
Madam, just one question. Is FAB related to the scores of the MMSE? That it is said that if your scores are very low, then FAB loses its value.
Yeah, if you have severe cognitive impairment, you cannot ask a person similarities between orange and potato, and you cannot ask them certain abstract questions. So you have to, it's not that you can do this test when you cannot do that test, but it's more a question of if he can comprehend and pay attention and understand, can he understand the instructions of the FAB, and then how reliably can you interpret the results. It's true if the cognitive impairment is very severe due to low MMSE, many of the tests cannot be done. Yeah. Right. So now you quickly go to the MRI. You can skip a few slides, just show us the classical findings. You have 30 seconds.
Yes, so MRI brain coronal section showing temporal as well as frontal atrophy, insular atrophy as well. And here we can also see that there is parietal atrophy, bilateral. Here again in the sagittal section, we can see that there's parietal atrophy and frontoparietal atrophy. Here on the coronal section, we can see midbrain atrophy, which is quite severe. The midbrain pons angle, the ratio that we can see is it's quite decreased. And also there is callosal atrophy. Here we can see the morning glory sign of PSP. So yeah, so it is frontotemporoparietal atrophy with hummingbird and morning glory sign.
Diagnosis.
So an overlap syndrome, frontotemporal dementia with CBS, with PSP, probable tauopathy.
So this is a patient who's probably read all 3 chapters and come to us, and we will go to the, I'll just spend a final conclusion on this and then we can stop. Next. No. Next. So this is the criteria for behavioral variant FTD. You can see this person fulfills it. Behavioral disinhibition, apathy, and loss of empathy. Next. Imaging showing frontotemporal atrophy. So is this a behavioral variant FTD? Fulfills criteria. Next. You have the PSP criteria, and you have vertical gaze palsy, unprovoked falls, and a frontal cognitive behavioral presentation. Fulfills criteria for progressive supranuclear palsy. Is it PSP? Next, corticobasal syndrome, insidious onset, asymmetric presentation of an apraxia with limb dystonia and rigidity. Yes, possible corticobasal syndrome. So here you have a patient who fulfills all 3 criteria of 3 different, apparently 3 different diseases. Next. So just to say that the time has, while many patients can actually fit into one or the other criteria, and they can be fairly fit into a set of criteria. In frontotemporal dementia syndromes, they're extremely heterogeneous. There are many overlapping symptoms. Indistinct phenotypic boundaries exist between FTD syndromes. For instance, executive dysfunction is common across all symptoms. But changes in behavior, while they're characteristic of BVFTD, they're also seen in PSP, CBS, and progressive aphasias. No, go back.
Sorry.
Language impairment can be seen across all FTD syndromes. You can have a PSP with non-fluent aphasia, CBS with non-fluent aphasia, and behavioral inherent FTD can develop semantic impairment or non-fluent aphasia. And to make things more complicated, movement disorders typical of PSP and CBS can also develop in patients diagnosed with behavioral variant FTD and PPA. That's a progressive aphasia. So when you talk about a trans-diagnostic approach, and this has been used in psychiatry, you're talking about what are the core symptoms that help you make a diagnosis rather than using criteria to make diagnosis. Next. And this case, I think this patient was prepared by Prachi and Dr. Rakesh, and it's very, very current because this is a publication this month in Brain, where a group from Cambridge looked at more than 300 patients of frontotemporal dementia, Carolyn Patterson, Matt, Ralph, and you can see in A, you have BVFTD coded in red, PSP in blue, CBS in green, non-fluent primary progressive aphasia in purple, and semantic variant in orange. So there are different codes for different diagnoses. But when you actually look at the group of people, you can see in the Venn diagram that 1/3 of people who were diagnosed PSP had overlapped with CBS, about 44% of CBS overlapped with PSP. So while there are some people who stay true to form, there are many different combinations that can occur. And I think what's important for us to remember that you can face in a particular patient a kind of phenotypic continuity without clear separation between phenotypes. Why this is important? Because certain combinations suggest a certain pathology in this patient. It could be a tau pathology. Treatment strategies are now are being aimed for a particular pathology and not for the clinical syndrome. So it's really important for us to phenotypically characterize them and understand that they're heterogeneous. So I really like to congratulate your team in JJ Hospital for really, really picking up a very important case, which is very topical, and also for an excellent presentation. And thanks to Prachi, Reshma, Fahim for organizing this discussion, Dr. Kadilkar for initiating this, and we are 7 minutes over time. I'm stopping.
No. I think we wish that you could just go on and on.
No.
It was such a fantastic discussion. We must first of all thank you for sort of organizing and conducting it beautifully. I think there are over 300 people in the audience, and there are at least 53 questions here now. So I think it just goes to show how interested everybody has been. And I must say for myself, I've learned quite a bit today. So thank you very much, Suvarna, for arranging this, and Fahim and Reshma for helping. Prachi, of course, presents very well. Prachi, your teachers will be happy the way you presented.
Actually, I would like to congratulate her teachers. I'm sure she's very good, but she's been taught the concept so well. So really, congratulations.
Rakesh is one of them. Rakesh is one of them. Yeah.
Thank you, Rakesh.
Thank you, ma'am, for all the help that you've done.
So I think we had a very good beginning today, and I'm sure these clinical sessions will go as well as the theory sessions. And I personally think the theory you can read, but these sessions are more relevant because here you really learn from the experts. So next week, we're going to have 2 short cases. They're both very good cases, and I'm sure you'll have very good experts. So I think we started well, but if there are any suggestions or if there is anything that you think would improvise, please do let us know, and we'll take as much as we can. So I think with that, shall we thank Devashish and Rakesh for preparing this and close the session. Devashish, Rakesh, any announcement before we close?
Next time we are planning to keep 2 short cases. And maybe if time permits, then probably we'll have some spotters of quiz. But this was absolutely wonderful. I mean, really enjoyed it. Absolutely fantastic presentations.
Yeah.
Thanks.
Devashish, you have any announcement?
So it's really phenomenal, and it was a wonderful evening. I do invite everybody for the Sunday morning sessions and then the theory sessions for the Tuesday evenings. They will be equally wonderful.